Now, besides 5-HT2A antagonism and 5-HT1A partial agonism, there are certain antipsychotics. Some will call them third generation antipsychotics. It depends on the reference. They have a unique pharmacologic action in that they are D2 partial agonists, like aripiprazole and brexpiprazole. There's a third one called cariprazine. It's in the US. Now, how does this decrease EPS hyperprolactinemia? Well, if the antagonism, even though more receptors are bound, but they are not, the response is not fully antagonized, it's only a partial agonism. Relative to an antagonist, there is some response compared to an antagonist, but compared to an agonist, it is an antagonist. Damning words. But basically, there is less of an antagonist effect for aripiprazole and brexpiprazole, regardless of the number of receptors bound. Less EPS, less hyperprolactinemia. And indeed, we do see that. And because of these additional receptor binding profiles beyond 5-HT2A, 5-HT1A, we also have 5-HT2C antagonism. So you think back to fluoxetine, 5-HT7 antagonism, and alpha-2 antagonism. Alpha-2 antagonism, that's sa NASA. We will discuss those sa antidepressants. These pharmacologic actions may also explain the antidepressant and mood-stabilizing properties of the second-generation antipsychotics. In particular, aripiprazole, thiopine, olanzapine, risperidone, even brexpiprazole are used as adjuncts in major depressive disorder. And a lot of them, almost all of them pretty much, are used in bipolar disorder. So in first generation, we usually reserve first generation antipsychotics as last line agents. Second and third generation antipsychotics, they're used frequently in the Philippines as mood stabilizing agents in bipolar disorder. And some of these can also use as adjuncts. Also later we'll talk about the indication. I'm getting ahead of myself.